Say goodbye to monotonous books and say hello to colorful, interconnected mind maps. In this series, we will quickly help you revise important concepts with the help of mind maps, which you can access later using our app. In this video, we will quickly revise important allergic and immunologic diseases of the oral cavity. First, we will talk about writer's syndrome, now known as reactive arthritis. It is a type of inflammatory arthritis that typically follows an infection. It predominantly affects young adult men. The classic clinical features of writer's syndrome include urethritis, which is the first sign, followed by conjunctivitis, arthritis, balanitis, and mucocutaneous lesions. Its differential diagnosis includes gonorrhea. Oral manifestations of writer's syndrome can include painless, red, slightly elevated, granular or vesicular areas on the buccal mucosa, lips, and gingiva with a white circinate border. Differential diagnosis can be recurrent aphthous lesions. Palatal lesions may appear as small, bright red purpuric spots. Tongue lesions may resemble geographic tongue, which is characterized by irregular map-like patches on the tongue surface. Treatment for writer's syndrome involves managing the underlying infection if present. Spontaneous remission can occur in some cases. Antibiotics may be prescribed to treat the infection. Corticosteroids and other anti-inflammatory medications may be used to manage joint inflammation and pain. The next condition we will see is Behçet's syndrome, which is associated with the HLA-B51 allele on chromosome 6p21. Behçet's syndrome is more commonly observed in individuals between the ages of 25 and 40, with a higher prevalence in males compared to females. The disease involves multiple symptoms and may present with oral and genital ulcers, arthritis, skin lesions, ocular movement, gastrointestinal manifestations, and neurological symptoms. The oral manifestations or genitourinary lesions are often one of the first signs of the disease. The oral ulcers have an erythematous border and are covered by a grey or yellowish exudate. They can occur in unusual locations such as the soft palate and oropharynx. The appearance of the oral ulcers is similar to that of recurrent aphthous ulcers. Behçet's syndrome may present with hypergammaglobulinemia. There may be leukocytosis with eosinophilia and ESR may be elevated, indicating inflammation in the body. There is no specific cure for Behçet's syndrome, and treatment mainly focuses on managing the symptoms and providing supportive care. Medications such as corticosteroids and immunosuppressive drugs may be used to control the inflammation and reduce the severity of symptoms. Angioedema, also known as angioneurotic edema, Quiniquet edema, or giant urticaria, is another clinically important condition you need to know about. It is a sudden and localized or diffuse, non-pitting edematous swelling that affects the skin, mucosa, and submucosal connective tissues. It can be due to mast cell degranulation, triggered by an allergic reaction. Some individuals may develop angioedema as a side effect of angiotensin-converting enzyme, ACE inhibitors. Activation of the complement pathway, which is part of the immune system, can lead to angioedema. It can also occur in patients with elevated peripheral eosinophil count. Angioedema is characterized by soft, non-tender, and diffuse edematous swellings that occur relatively rapidly. It most commonly affects areas around the face, including the lips, chin, eyes, and tongue. It can also involve the pharynx and larynx. In hereditary forms of angioedema, there can be involvement of the respiratory and gastrointestinal symptoms, which makes it potentially more dangerous. Identifying and eliminating the underlying cause of angioedema, such as allergens or trigger factors, is essential in managing the condition. Antihistaminic drugs, corticosteroids, and in severe cases, intramuscular epinephrine may be administered. The last condition we will discuss in detail is contact stomatitis, also known as allergic contact stomatitis or contact dermatitis. It is a type of localized reaction in which a lesion develops on the skin or mucous membrane after repeated contact with a specific causative agent. The causative agents are typically chemical substances, haptens, that require conjugation with proteins to become effective in causing the reaction. Common causative agents of contact stomatitis in the oral cavity include dental or cosmetic preparations such as dentifrices, mouthwashes, denture powders, lipsticks, candies, cough drops, and chewing gum. Dental materials such as rubber dam, vulcanite, acrylic, metal alloy, base, etc. Dental therapeutic agents, for example, alcohols, antibiotics, iodides, phenols, procaine, volatile oils, etc. Patients may experience itching or a burning sensation at the site of contact, followed by the development of erythema and vesicle formation. Oral contact stomatitis is relatively rare. The oral mucosa becomes inflamed and edematous, with a uniform bright red appearance in all quadrants, which distinguishes it from plaque-induced gingivitis. The affected tissues may be subject to erosion and ulceration, particularly in the lips. Histologically, contact stomatitis shows intra and intercellular edema of the epithelium, along with vesicle formation within the epithelium or at the basement membrane. The most effective treatment for contact stomatitis is to discontinue all contact with the offending material or agent causing the allergic reaction. Symptomatic relief can be achieved with topical corticosteroids and/or antihistamines. There are various metals that can be ingested and can cause toxicity reactions, such as mercurial toxicity and lead, bismuth, and arsenic poisoning. You can note down points about each one of these in detail from this section of our mind map. With this, we have come to the end of this video discussion. Hopefully, we have helped you revise this topic quickly. Now, you can head over to the MCQ section of our app for solving some questions. Happy learning!